These all are the peripheral stigmata of tuberculosis. So what is this lesion? Quick.
So the first one is lupus vulgaris.
Good. What is this?
So this is scrophaloderma.
Okay, that is skin tuberculosis. Okay. What is this?
Conjunctivitis.
Which conjunctivitis? Flectanicular conjunctivitis. Good. Yeah, try.
So
What are these lesions?
erythema nodosum, sir.
Very good. What is this?
Varicosa cutis.
Okay, and
Papillonecrotic tuberculosis.
excellent. Good. Take your seat. Next. Yeah, any Prince, identify the lesion quickly.
So first one is the oral candidiasis.
Candidiasis, okay.
Herpes zoster.
What are these?
Kaposi sarcoma.
Good. What are these lesions?
Molluscum contagiosum.
Okay. What are these?
Seborrheic dermatitis.
And this one?
Oral hairy leukoplakia.
Okay. So rightly says these all are peripheral signs of HIV that we always in general examination in any of these multi-system case, the peripheral stigmata of basically tuberculosis and HIV is of paramount importance, and we should always look for this. Next.
Respiratory system examination, he was using accessory muscles of respiration. Trachea was central. The chest wall had decreased movement on the right side, and it was stony dull on percussion in right intrascapular, intraaxillary, and left intraaxillary area with absent breath sounds in the same regions on auscultation. In abdominal examination, he had tenderness over epigastrium and left hypochondrium. Spleen was palpable 6 centimeters from left subcostal margin along the splenic axis, and shifting dullness was present. In nervous system examination and cardiovascular examination were essentially normal.
Okay, Akash, can you summarize? Now you have history of the patient as well as the clinical examination. Just summarize.
The 30-year-old serving soldier male known case of PLHIV with previous history of OIs in form of TB, now presented with 2-week history of fever, cough, dyspnea, unintentional weight loss. Clinical examination revealed lymphadenopathy and features suggestive of likely pleural effusion on the right side.
Okay, with ascites and
ascites.
organomegaly also, splenomegaly. So what are the possibilities based on the clinical examination as well as your findings?
The first differential which we are thought after the history, TB still remains a differential here. It can be a disseminated TB with past history of TB, poor compliance to ATT.
Okay, so how do you define disseminated TB? What is the definition for disseminated TB?
Sir, involvement of 2 or more organs, non-contiguous.
Non-contiguous?
Or more organs.
Okay, so is malaria TB is considered as a disseminated TB? Yes or no? You are not confident. Yes or no?
Yes, it's a
yes. It's again a disseminated TB. Okay. So this is one of the possibilities. What else?
He has splenomegaly. He has multiple lymph nodes, and in an underlying background of HIV, lymphoma can also be a possibility.
Okay, taken. Anything else? Yeah, Abhishek, would you like to add something more on the possibilities?
In the background history of alcohol consumption, sir, with features of ascites and splenomegaly, portal hypertension can also be considered at this stage.
Okay, right. Proceed.
His investigation at Kaman Hospital, Bangalore, revealed pancytopenia with hemoglobin of 11.9 gram per cent. PLC was 3,200 cells per cubic millimeter, and platelet count was 110,000 cells per cubic millimeter. His ESR was slightly elevated with 40 millimeters was the reading, and he had hypoalbuminemia with AG reversal. His tropical infection workup in the form of dengue, malaria, and typhoid was negative. His CD4 count was 77 cells per microliter. His torch panel had revealed CMV and rubella IgG reactive. His sputum for CBNAT had detected Mycobacterium tuberculosis with rifampicin resistance, and pleural fluid analysis had revealed an exudative feature with raised LDH and cytology of 420 WBCs, which was lymphocyte predominant. And CVNAT of pleural fluid also had revealed Mycobacterium tuberculosis with rifampicin resistant.
Just hold on. Any microbiology resident? So, yeah, so pleural fluid, it is considered as a suboptimal specimen because these tubercular bacilli are more in pleural fluid or the chest wall, where it is more. Fluid or chest wall?
Fluid.
No, it is other way around. So it is more in chest wall. Now my second question is, what is the maximum volume of pleural fluid which is required for processing for the culture? So a medicine resident is sending the samples. He may send you 5 ml, 10 ml. So what should be the minimum quantity which is supposed to be sent for?
5 to 10 ml.
No, it is always a range. Anyone? Any other resident from microbiology?
It is approximately 5 to 10 ml.
No, for culture I'm asking. So it should be minimum 20 to 50 ml. Okay. Okay. For processing of the culture, 20 to 50 ml should be the minimum one. Okay. Next. So again, can I have anyone from pulmonology? Resident from CTC? So induced sputum versus bronchoscopy. So tell me the sensitivity and specificity as far Jordan staining is concerned and culture is concerned.
So for sputum, the sensitivity is 30%, sir. And for bronchoscopy, it is around 35. It is more than sputum, sir. And for specificity, it's almost 100%, 99%.
Okay. Next. So what is Light's criteria? Any undergraduates want to take over these questions? His pleural fluid has been examined. So what is Light's criteria? Just tell the salient points.
The pleural fluid is exudate when the pleural to serum protein ratio is more than 0.5. The pleural to serum LDH ratio is more than 0.6 and the pleural LDH ratio is more than the 2.3 of the upper limit.
Okay, so is there any fallacies for Light criteria? Want to take over these questions? Or, yeah, any final year? Yeah, Rajesh, what are the fallacies for Light's criteria?
Sir, Light's criteria overestimates the exudative because any one of them, if positive, the fluid is considered as exudative. So 25% of transudates are also classified as exudative pleural fluid, sir. So to overcome that, sir, we use SPAG, sir.
What is SPAG?
Serum protein, serum pleural albumin gradient, sir. So we take the difference of serum protein and pleural fluid protein.
So rightly say if this gradient is more than 3.1 gram per deciliter, the exudative categorization by this criteria can be ignored because almost all such patients have a transudative effusion.
Ultrasound at Kaman Hospital, Bangalore had revealed ascites, splenomegaly and right side pleural effusion with normal liver echo texture. His CT scan of chest and abdomen had revealed scattered miliary nodules in bilateral lung fields with mediastinal, right hilar, cervical and left axillary lymph nodes, and many of them were necrotic. He had bilateral pleural effusion and he had ascites with enlarged mesenteric lymph nodes with omental caking, and he has splenomegaly. The differentials at this stage given by radiologists was disseminated tuberculosis.
So again from chest, any resident from pulmonology, just tell the molecular detection techniques and what is the turnaround time for different and why it is important.
Molecular detection techniques are very important because they reduce the turnaround time as compared to the liquid culture, which is 42 days. So first we do a gene.
So what is for TrueNat? What is for Gene Expert?
There are two types of nucleic amplification tests like TrueNat and Gene Expert. Gene Expert is a one-step process. It takes around 2 hours, sir. TrueNat is a two-step process. It takes 1 + 1 hour for both processing and drug sensitivity, sir. Then we come to first-line LPA, which takes both H and R, and turnaround time is 72 hours, sir. And
okay. So 1 to 3 days for LPA. Okay. So and why this is important?
Because they are rapidly testing the drug resistance, sir.
And whenever we are, more important is we always send the sample. So as a resident, we should be aware. Okay. So it should not come after say 2 days, 3 days. CVNAT 2 hours is the turnaround time. So they should be able to give you. So you should chase the result. Okay. Fine. Next. So Again, any undergraduates can take over this question. Monoresistant TB, isoniazid resistant TB, polydrug resistance. Just keep defining one line definition.
So monoresistant is when it is resistant to any first line drug. Isoniazid when it is resistant to
Okay.
isoniazid. Polydrug when it is resistant to any two first line drugs, but not isoniazid and rifampicin together.
What are MDR, pre-XDR and XDR?
So MDR is when it is resistant to isoniazid and rifampicin. There may be resistance to any other first line drug. So pre-XDR is MDR plus there will be resistance to fluoroquinolones. And then XDR is pre-XDR plus resistant to
Yeah, good.
methaquilin or linezolid.
Very good. Okay, so XDR is MDR, rifampicin resistant to fluoroquinolone plus one additional group A drug, that is either bedaquiline or linezolid. Have you heard about bedaquiline? The undergraduates? Which group of drug is bedaquiline? Any pharmac resident? Resident from pharmacology. So tell me few of the newer, this is the part of the newer drug regime. What is bedaquiline? Which group of drug is this? Close to your mic.
So
Yeah.
bedaquiline comes under darinquilin group of drugs, sir, and it actually works by inhibition of ATP synthesis of the bacteria, and it is bactericidal, sir. It is included in the BPAL regime and group A of the.
What are the adversities of this drug?
Sir, it is not to be used in. Sir, it is not to be used in the. In case of patient who are already having QT prolongation, sir, one of the peculiar side effect is that. And in case of
So conduction defect, arrhythmias, cardiac conduction defects. What else?
and sir, hepatotoxicity.
Okay. Any specific instructions would you like to give to the patients if you have to initiate this drug?
Sir, it is to be taken with high fatty food, sir. The absorption is.
So along with
Yes, sir.
food or anything else, suppose somebody is having gastritis and you want to use some Gelusil or some antacids. So can they take it or not?
Sir, because it causes chelation, sir, of it, sir. Calcium.
Why it causes changes? So all these magnesium containing antacids, they can actually defer the absorption. So you have to tell, even if they have to take after 2 hours using this drug. Okay. Okay, fine.
So, coming to the integrated diagnostic algorithm, all presumptive TB cases or all TB patients and who are non-responding to therapy should go and upfront CBNAT at the time of presentation to DOT center or in a OPD. And if a rifampicin resistance is detected, they have to undergo a first line LPA, second line LPA, and a liquid cultured drug susceptibility testing. And if rifampicin resistance is not detected, then first line LPA is sufficient.
So this is as per the latest guideline by National Tuberculosis Elimination Program. This is the algorithm which we are supposed to follow. And CBNAT can be done on what all samples? Yeah, any macrobiology, resident from macrobiology. What does it stands for, CBNAT?
So cartridge-based nucleic
Okay.
acid amplification test. So CBNAT can be done in various samples like sputum, ball sample, then extrapulmonary sample like CSF, synovial fluid, pleural fluid, and
So
even
can be done on any body fluid sample.
Yes.
Can be done. Okay. Yeah. So can we have any resident from PSM? What is the burden of tuberculosis in India?
Sir, according to the WHO global report in 2023, it is defined as rate per 1 lakh incidence, and that is around 199 per 1 lakh for incidence of TB cases. That comes to around 28 lakh per year. And
What about the MDR and all? This?
sir, MDR cases are around 3.5 per 1 lakh, which comes to around 50,000 per year.
Okay, and what is the treatment success rate with the older regime vis-a-vis the newer BPAL regime, which is now in use?
So with the older